Hypogonotrophic hypogonadism is defined as hypogonadism as a result of gonadotrophin deficiency. Diagnosis made by in the presence of low LH, FSH, estradiol, and testosterone. Rest of the pituitary function is normal. MRI would show small pituitary gland, normal hypothalamus. Gonads would be small. They would be absent or delayed puberty, and patient would have a primary amenorrhea. You would be told stature from the delayed closure of the epiphysis, anosmia, absent olfactory bulbs, and MRI in Kalman syndrome. So the causes of hypogonotrophic hypogonadism, single gene defects include Kalman syndrome, IHH, functional is related to exercise, weight loss, stress, systemic illness, iatrogenic because of the anabolic steroids and opioids, associated conditions like hemochromatosis, CH especially in male, pituitary disease, syndromic like Prader-Willi syndrome, Loris Mohnweidel syndrome, Chart syndrome, and X-linked adrenal hypoplasia congenita. It is usually associated with other pituitary hormonal deficiencies whenever there is any structure pathology. In children, craniopharyngiomas are the most common cause. Cranial radiation for leukemia or brain tumors may also result in secondary hypogonadism. The commonest lesion in adulthood are prolictinomas. So the prolictinomas are the most common cause of hypogonotrophic hypogonadism in adult patient. Systemic illness, like any severe illness, can cause hypogonotrophic hypogonadism. Prader-Willi syndrome, it's a congenital syndrome caused by the loss of an imprinted gene suspected in infancy, the presence of the facial characteristics, facial features. These patients tend to have hyperphagia with morbid obesity, and they are at the risk of developing type 2 diabetes. Chart syndrome it's the association of coloboma, heart anomalies, corneal atresia, mental retardation, genital and ear anomalies, and proportions would also, and some patients would also have hypogonotrophic hypogonadism. So systemic illness resulting in hypogonadism include any acute illness, be it myocardial infarction, sepsis, and head injury. And that's the reason that these hormones should not be tested in acute cases. Severe stress, hemochromatosis, because of the deposition of iron in the pituitary gland. Endocrine disease, including the Cushing syndrome and hyperprolactinemia, liver cirrhosis, chronic renal failure, chronic anemia, especially thalassemia major, and sickle cell disease. GI disease like the celiac disease and Crohn's disease, AIDS, rheumatological disease like the rheumatoid arthritis, respiratory disease, including COPD and cystic fibrosis, cardiac disease, including the congestive cardiac failure. X-linked adrenal hypoplasia congenita. It's a rare X-linked or autosomal recessive disease. It is caused by the mutation of the TEX gene, which is located on X chromosome. It presents with a primary adrenal failure in infancy, and there would be hypothalamic hypogonadism in these patients. Management is androgen replacement therapy, estrogen replacement therapy in females. When fertility is desired, testosterone is stopped and exogenous gonadotrophins are administered. In primary hypogonadism, it is due to testicular failure with normal hypothalamus and pituitary function, and the diagnosis made by the 9 AM serum testosterone, which would be low, but there would be increased level of LH and FSH, low inhibin B, and AMH. Since these are inhibin B and AMH are produced by the testes, these would be low in the primary hypogonadism, and these would be normal in case of secondary hypogonadism. So the causes of primary hypogonadism include Klinefelter syndrome, It's the most common congenital form of primary hypogonadism. It is um, basically it is associated with a characteristic clinical manifestation that would depend on the age of diagnosis. Patients with mosaicism tend to have less severe clinical features. If these patients are diagnosed in adolescence, then it is found to have they will found to have a small firm testes, usually less than 5 ml. They would have gynecomastia, tall stature with increased leg length. Other features of hypogonadism would also be present and would have cognitive dysfunction. If diagnosis made in adulthood, they will have reduced libido and erectile dysfunction. Gynecomastia is present in 50% of the patient. Reduced facial hair and infertility would be a pronouncing feature. And furthermore, these patients tend to be obese. Most of these patients are at a risk of type 2 diabetes mellitus, osteoporosis, thromboembolism, and malignancies, especially extragonadal germ cell tumors. Diagnosis made by the karyotyping, and it is they're expected to have 46 XXY in 80%, high-grade chromosomal aneuploidies, including 48 triple XY, or 46 XY, 47 XY mosaicism in the remainder. So since these patients have low primary hypogonadism, the testosterone would be low. They would be elevated FSH and LH, elevated sex hormone binding globulin and estradiol would also be present in these patients. And when the semen analysis is done, they would have azoospermia. Management would include lifelong androgen replacement, may need surgical reduction of the gynecomastia, and fertility is desired. In Hcg would be a reasonable option using testicular spermatozoa from men with Klinefelter syndrome as a result in successful pregnancies. Testicular dysfunction, clinical characteristics of male hypogonadism. When the testicular failure occurs before the onset of puberty, the testis volume would be less than 5 ml, penis would be less than 5 centimeter long, there would be lack of scrotal pigmentation and rugae, gynecomastia would be pronounced, they would have high pitch voice, there would be central fat distribution and echinatism with arm span 1 centimeter greater than the height, and the lower segment is greater than the upper segment. Furthermore, they would have delayed bone age, and there would be less body and facial hair. When the testicular failure occurs after puberty, the testis would be soft and the volume would be less than 15 ml, but greater than 5 ml. The penile length would be normal. There would be normal skeletal proportion. Gynecomastia can be present in these patients as well. There would be normal hair distribution, but reduced in amount. The skin would be pale with fine wrinkles. There would be central fat distribution. Osteoporosis would be present in these patients, and anemia of the mild intensity can also be present. Other chromosomal disorders include XX male. It is basically due to X to Y translocation with only a part of the Y present in one of the X chromosome. And they have similar clinical biochemical features of Klinefelter syndrome. In addition, they would be short stature and they would have hypospadias. So basically, they will have basically these are XS male, but as compared to Klinefelter, in contrast to Klinefelter, they would be short, and apart from the hypogonadism, hypospadias would also be present in these patients. Then XX and XO, that is mixed gonadal dysgenesis. Occasionally phenotypically male with hypospadias and intra-abdominal dysgenetic gonads would be present. Bilateral gonectomy is essential because of the risk of Neoplasia followed by the androgen replacement therapy. XYY syndrome, they are taller than average, but often have primary gonadal failure with impaired spermatogenesis. Y chromosome microdeletion, they will cause oligo or azoospermia. Testosterone levels are not usually affected. Noonan syndrome, it is autosomal dominant disorder and with the incidence of 1 in 10,000. They have 46 XY karyotype and secondary external genitalia. However, several stigmata of Turner syndrome, like dysmorphic facial features, short stature, webbed neck, low set ears, and lymphedema, and increased risk of cardiac anomalies, including valvular pulmonary stenosis and hypertrophic cardiomyopathy. Most have cryptocardism and increased testicular failure, may have a bleeding tendency. Hypogonadism, 10 to 20% neonates have undescended testes, but most of these would descend in the scrotum eventually. So the incidence of post-pubertal cryptocardism is less than 0.5%. 15% of the cases have bilateral cryptocardism. 75% of the male with bilateral cryptocardism are infertile. 10%, there's a 10% risk of testicular malignancy. Highest risk in those with the intra-abdominal testes. Low testosterone and raised gonadotrophin is present in bilateral cryptocardism. Treatment is by orchidopexy, which is best performed before 18 months. Currently, certainly before the age of 5 years in order to reduce the risk of later infertility. Gonectomy in patients with abdominal testes followed by the androgen replacement therapy should be considered in these patients. Orchitis, 25% of the male who develop mumps after puberty have associated orchitis, and up to 50% of these will develop testicular failure. HIV infection may also be associated with orchitis. Primary testicular failure may occur as a part of autoimmune disease. Cytotoxic therapy, particular alkylaging agents are gonadotoxic. Infertility occurs in 50% of the patients following chemotherapy from most malignancies, and significant number of male would require androgen replacement therapy because of the low testosterone levels. The testes are radiosensitive, so hypogonadism can occur as a result of scattered radiation during the treatment of Hodgkin disease, or for example, if fertility is desired, sperm should be cryopreserved. Other drugs include sulfasalazine, colchicine, and high-dose corticosteroids may reversibly affect the testicular function. Alcohol excess may also cause primary testicular failure. Testicular trauma can also lead to loss of testes and may affect the function of the remaining testes. So the clinical assessment of hypogonadism, development history should be asked, especially regards to congenital urinary tract abnormalities like hypospadias, late testicular descent, or cryptocardism, delayed or incomplete puberty, infections, mumps, and orchitis, abdominal or genital trauma should be inquired, testicular torsion, anosmia, drug history, species sulfasalazine, antihypertensives, chemotherapy, cimetidine, radiotherapy, and recreational drugs. In the general medical history, we should ask about the chronic illness, particularly respiratory, urological, and cardiac pathology. Gynecomastia is common, and especially during the adolescence. Recent onset gynecomastia is in adulthood. We should rule out estrogen-producing tumor. Family history is important because in Young syndrome, which is associated with reduced fertility, bronchiectasis, and rhinosinusitis, cystic fibrosis, and Kallmann syndrome often runs in families. Sexual history is also important while evaluating these patients. In the physical examination, there would be less hair distribution. There would be muscles and fat distribution should also be evaluated. And gynecomastia can be appreciated in these patients. Pubic hair is normal could be normal in male patients. Phallus would be normal, greater than 5 centimeter and greater than 3 centimeter, depending on the age of onset of hypogonadism. The testis size and consistency should also be as certain. Usually the normal testes are greater than 15 millimeter, and it is basically firm in consistency. General examination, look for the evidence of systemic illness and peripheral pulses. Rectal examination and general sense of smell should also be evaluated. So the hormonal elevation of testicular function, serum testosterone, it should be checked at 9 a.m. Sex hormone binding globulin, only 2 to 3, up to 4% of the circulating testosterone is unbound, 50 is bound to sex hormone binding globulin, and rest to albumin. Concentration of sex hormone binding globulin should be taken into account when interpreting a serum testosterone result. Shbg levels may be affected by the variety of conditions. It is important to measure Shbg when testosterone are under the normal range. LH and FSH should be evaluated. These would be raised in primary testicular failure and inappropriately low in pituitary or hypothalamic gonadism. So causes of raised SHBG include androgen deficiency, growth hormone deficiency, aging, thyrotoxicosis, estrogens, and liver cirrhosis. And low SHBG, causes of low SHBG are hyperinsulinemia, obesity, acromegaly, androgen therapy, and hypothyroidism, Cushing syndrome, and nephrotic syndrome. And the causes of raised estrogen in male include tumors, particularly the testicular tumor, adrenal tumor, and hepatoma, primary testicular failure, liver disease, thyrotoxicosis, obesity, androgen resistant syndromes, and anti-androgen therapy. Inhibin and AMH, gonadal glycoproteins. These are the gonadal glycoproteins which are secreted into the circulation. These are useful markers of the normal testicular function. They are low if primary testicular failure is present and would be normal if pituitary or hypothalamic dysfunction is there. Scrotal ultrasound is important. Semen analysis should also be taken. Male with low sperm count should consider sperm cryopreservation. So the dynamic tests include of limited clinical value and thus are purely performed routine, not rarely performed routinely. Hcg stimulation test, Homophine stimulation test are the two important tests while evaluating the hypogonad patient. So the Hcg stimulation test, it's a diagnostic test for examining the Leydig cell function. Hcg 2000 international unit I am given on day 0 and 2. Testosterone is measured on day 0, 2, and 4. And prepubertal boys with absent scrotal tissues, testes, a response to Hcg indicates intra-abdominal testes. Failure of testes to rise after Hcg suggests absence of functioning testicular tissue. An exaggerated response to Hcg is seen in secondary hypogonadism. Homophine stimulation test used to assess the integrity of the HPA testicular axis. Normal response to 3 mg per kg with a maximum of 200 mg clomiphene daily for 7 days is a twofold increase in LH and FSH measured on days 0, 4, and 7. And subnormal response indicate hypothalamic or pituitary hypogonadism, but does not differentiate between the two.